Hello, everyone. As part of our series on investigations in ophthalmology, I wanted to go through visual fields today. So, visual field assessments, there's lots of different types, and I think one of the struggles are sometimes if you're looking at a visual field in isolation, is a sort of figuring out what you're looking at, but also what you're looking at might indicate. And it's important to remember that visual fields are to be taken as part of an entire examination of a patient, so including your clinical exam, the history, alongside other investigations like OCTs. But I wanted to focus on visual fields today, and we're also going to spend some time looking at the different patterns that you can see on a Humphrey, and what they might indicate. So starting off, like I said, there's lots of different ways of doing things. So you've got your basic sort of confrontational visual field, just a sort of rudimentary looking at the four quadrants of somebody's field. An Amsler grid is a type of visual field assessment. It's a very much sort of your central few degrees, monitoring things like CNV, in particular wet AMD and things like that. And then your two main types are your kinetic perimetry and static perimetry. And really the difference is the light that the patient is looking at, does it move or does it not? Um, so if it's moving, you're looking at kinetic perimetry, and if it's not moving, you're looking at static. So it's sort of, it's pretty obvious from the name. But your typical sort of Humphrey perimetry is an example of your static, whereas when you're looking at kinetic perimetry, it's more things along the lines of, for example, like your Goldmann perimetry. Um, so starting off with Goldman perimetry, it's kinetic. It tends to be more static for the central few degrees of the vision, but generally as a parametric test, it's kinetic perimetry. And the way it works is you have an operator that moves a light, and the patient is asked to then, say when they can start to see the light within the field. So you can imagine it requires somebody who knows what they're doing. And it is very useful for those with very advanced loss of field. And it's actually also very useful for those who require a lot of supervision in terms of maintaining fixation. So if you leave somebody on a Humphrey test, they're going to lose fixation a lot. And that sort of patient might need somebody with someone in the room or doing a Goldman perimetry to try and keep them focused for as much as possible. So, for example, in children or in patients with learning difficulties, the Goldman perimetry can be quite handy. And you've got different levels of both intensity and size of the light. So, you might find sometimes when you're looking at exams, some questions might ask you what a specific number or letter means. So between 1 to 4, you've got sort of so 1, 2, 3, and 4, 0, 5, 10, and 15 decibels. And then you've got sort of 1A, 1B, or 2C, for example. And the letter adds a smaller unit of decibels. And then you've got 0, 1, 2, 3, 4, 5 in Roman numerals, and that gives you the size of the object in millimeters squared, starting at 1 over 16 and then multiplying by 4 with each grade. And the Goldman perimetry gives you a field that looks similar to this, where you'll have usually it's your sort of brightest lines on the outside and your faintest lines on the inside in terms of smallest and faintest objects can be seen in the central field where you've got higher contrast sensitivity and better acuity. And then in the peripheral field, so this is why you're noticing the Roman numerals are going up and the numbers are going up because you need brighter and larger objects for the patient to be able to see the object in the peripheral field. Um, and usually, if somebody is, so one of the ways that you can sort of try and see whether or not what you're looking at is perhaps functional or not organic in nature is when these lines cross, you shouldn't be able to, in a part of your field, it should be impossible where you can see a bright light, where you cannot see a bright light, but you can see a fainter light further out. So if these lines cross, you're sort of confused as to what might be going on. And that's just a sort of, you don't typically see a lot of golden perimetry unless you're doing a lot of work in pediatrics. But that was just a quick note on kinetic perimetry. And then the Humphrey field test is your sort of main thing that you're looking at. And the Humphrey has lots of different protocols. It has a lot of different algorithms that you can use on the Humphrey field test. You can do it with one eye, you could do it with two eyes. And the Humphrey field test can do an entire full field, which takes a long time. You can look at 30 degrees either side of the midline, 24 degrees either side of the midline, 10 degrees. And then there's different algorithms that I'll go into what they mean. Either you may have heard the SITA algorithm or the SITA faster or even a SITA fastest, and I'll go into what that means in a moment. You then have sort of different types of visual field in that you might hear something along the lines of either threshold or suprathreshold. So suprathreshold are usually the very quick ones to perform. These are sort of your screening tests. So they will use quite large steps in decibels. So they'll go up in the decibel in terms of the intensity of the light quite quickly. So you can imagine the field test will be quicker to perform, but it's less sensitive. So it's not as useful for things like glaucoma, for example, whereas if you want to monitor glaucoma, your threshold tests are your gold standard. You then have different reliability indices. So starting off with fixation losses, this is you have a tracker that looks at the patient's pupil and whether or not the patient has lost fixation during the test. And the way you might find that somebody, the way that manifests in the field test, you might find that actually they're able to see lights in the blind spot where they're not able to see things, and that's because they've lost fixation. Your false positives are essentially where a patient has responded where they shouldn't have seen a light. Or, for example, they may hear the machine click, but a light has not been pressed, and so they can press the button. And this can sort of happen with your sort of trigger happy patients. And then your false negatives are patients whom so they don't click the button where they have previously seen a less intense light. So essentially, you've already seen a light on a previous threshold at, let's say, 4 decibels, and then when shown something at 8 decibels, you don't press it. And that's a false negative because you should be able to see a brighter intensity light where you have previously said you have seen a lower intensity light. And these indices together sort of give you an understanding of how reliable what you're looking at is. If somebody has a lot of fixation losses, a lot of false positives, a lot of false negatives, you really need to take that visual field with a pinch of salt. Um, so do look at these reliability indices before deciding whether or not what you're looking at is a field deficit and B, progression of something like glaucoma. And then you have these sort of global indices. So you start off with a pattern standard deviation. So this takes it into account things like generalized depressions. So what that means is, for example, let's say somebody has a cataract and they've got a generalized depression across the entire field, then you might find that this, so the pattern standard deviation will take that into account and minus something like a cataract. You then look at short-term fluctuations. So this is essentially how consistent are your responses. So a threshold will be essentially tested twice and seeing whether or not somebody is consistent with what they're responding. And then the corrected pattern standard deviation is your pattern standard deviation corrected for your short-term fluctuation. And so the corrected PSD is usually one of the best things to look at when deciding whether or not someone has a field deficit and if things have progressed. So going into your sort of common abnormalities, there's a lot here. And it can seem quite like you're trying to remember lots of things in isolation, but remember, you're not just only ever going to see a field test for a patient. You might do for example, a referral from an optician, but normally you're going to have a history from the patient. You're going to know their medical history, their ocular history. You're going to get an understanding of whether or not it's a field deficit that the patient can even notice themselves. Are they symptomatic? Do they have any associated symptoms? And what does their eye look like? Have you assessed their anterior segment, their posterior segment? What does their disc and macula look like? And then you can look at that visual field in association with that. So an altitudinal field defect is essentially a field defect that respects the horizontal midline, and it typically presents things like ischemic optic neuropathies. You've got sort of hemiretinal, like either branch, so like vein occlusions, artery occlusions. Glaucoma can present with this sort of field defect. Typically problems with the optic nerve, or for example, optic nerve collobomas, lesions. These can present with altitudinal field defects, and this is sort of what it looks like. And importantly, it respects the horizontal midline. An arcuate scotoma is essentially something that follows an arc. And the reason it does is it typically is because there is a problem with a specific RNFL bundle. And so that bundle of fibers, which goes in an arc from your optic disc round to the retina and the peripheral retina, is all killed off. So you get this sort of arcuate field defect. And again, that's typically glaucoma. But you can find this again with ischemic optic neuropathy, or even something like like drusen, for example, can even give you this sort of picture. A nasal field defect is a field defect that typically is just at the nasal step. So this is usually your most common presentation in something like glaucoma. But in the context of, for example, if you have this bilaterally, again, you might be looking at something like glaucoma, or you might be looking at, for example, retinal disease, occipital disease, potentially even lesions at the chiasm can sometimes present with binasal. There are certain drug causes for binasal field defects, and sometimes even functional vision loss can present with this sort of thing because it's more the nasal field. Bitemporal hemianopia, this is something that's usually better understood, and that's because you're usually starting to hear about this sort of thing from medical school. But this is typically your chiasm. But interestingly, it can also happen with patients with, for example, sectoral retinal disease like RP, for example, or even patients who've had heavy temporal laser for whatever reason, can present with these sort of field defects. A central scotoma, if you think about where it is on the field, central vision tends to be something to do with your macula. So macular lesions can present with these sort of central scotomas, but they can also present with optic nerve lesions, optic neuritis, for example, atrophy, can also present with something like this. Homonymous hemianopia tends to be things behind the chiasm. So you're looking at the optic tract, your LGN, for example, lesions there, or for example, lesions in your temporal parietal lobes, and I'll touch on that in a moment. But essentially, a homonymous hemianopia is a hemianopia, and homonymous means it's the same side of the field in both eyes. Then you've got a generalized constriction of peripheral field, and this can happen again for both optic nerve reasons and retinal reasons. So glaucoma is a typical cause for this. Things like retinitis pigmentosa again, bilateral PRP can present with things like this. Retinal artery occlusions, particularly CRAOs, can present like this. You've got a typical sort of your occipital lobe lesions with macular sparing. Um, Things that can affect your entire optic nerve. So, for example, papilledema or even functional vision loss can also present with this sort of constriction of your peripheral field. And then almost the opposite to that is bilateral blind spot enlargement. Sorry, that should say blind spot. And this is things again like papilledema, optic nerve drusen, uh, problems with your sort of discs. So, for example, myopic discs can present something like this. Potentially even things like drusen, or even like more kind of rarer things like collobomas and stuff like that can present with something like this. And of course, optic nerve swelling can also present with an enlarged blind spot. And lastly, you might have heard things like pie in the sky and pie on the floor, and essentially that is talking about a quadrantinopa, either a superior or an inferior quadrantinopa. And your superior quadrantinopias are usually your temporal lobes, and then your inferior quadrantinopas with a pie on the floor are usually your parietal lobes. So that's a sort of quick run through of different abnormalities that you might find on a Humphrey. And what's important is that the more you're seeing things and the more you're kind of going through the pathologies, the more you'll understand things. And actually, you almost want to get to a stage where your field defects are predictable. You're sort of using them to confirm what you're already thinking, rather than using them solely to diagnose. Of course, in the context of glaucoma, they can be very helpful in asymptomatic patients in monitoring the progression of the disease. But if you've understood the pathology, if you've understood where the pathology is and what the pathology is affecting, your field defects can sometimes be quite predictable. So if you're looking at peripheral retinal lesions, if you've got lots of laser, if you've got lots of scarring, you can kind of guess where the field defect is going to be. If something is in front of your chiasm or behind your chiasm, again, you should be able to sort of start to guess where these field defects are. So use the field test as a confirmation, and B, it can be very helpful, obviously, in monitoring chronic disease as well. So just a comment, as I said previously, on the sort of protocol. So you've got something called the suite of interactive threshold algorithm, and this is much quicker than your traditional threshold algorithms, because what essentially it does is it uses previous test values to skip certain parts of the test. And that therefore it's much quicker, but because it's using previous data points, it maintains the reliability. So it's very helpful in patients who need chronic field assessments. So for example, patients with glaucoma, and it can establish threshold values much more quickly. And so this stands for SITA, and you've got the SITA algorithm, you've got SITA faster and SITA fastest. And this is why you're able to find some patients who are performing full 24-2 tests in 2 to 3 minutes. And that's because it's using the previous threshold set by previous data points, but maintaining the reliability of that test. And then finally, you've got the Esterman as well. And the Esterman you'll have heard being used mainly in things like the DVLA. And that's a binocular test. It looks at the central field. It can look at the whole field. That's what that should say, sorry. And it can also do a binocular field. It's a slightly different types of algorithm. It's a slightly different protocol on the Humphrey test. And the binocular test of the field for the Esterman is your test that's used for the DVLA. And then you can read up the specific DVLA requirements, which you'll need to know for your exams, but also generally when looking at your patients, you need an understanding of what the DVLA requirements are in terms of field. The Esterman is not usually something performed on the NHS here in the UK. You can usually just head over to a Specsavers to have the DVLA. You can go through the DVLA to book an Esterman field test if the patient needs it. So just to summarize, it's there's lots of different types of field testing, and different depending on the type of disease you're looking at, they might be indicated different for different reasons. So you might be using it for monitoring, you might be using it for diagnosis, you might be using it for asymptomatic patients. And the important thing is that you're putting that field within the context of your examination, the history and the investigations of the patient. And that brings us to the end. These sort of videos as part of this sort of series will be quite quick. It's essentially short bursts of videos that go through specific investigations, and they're just a quick sort of reminder as to when to use an investigation, how to sort of understand it, and the common sort of abnormalities that you'll find. So again, I really do appreciate the feedback. If you're watching this on YouTube, there's a link in the description. Please do fill that out. These videos are going to continue being free. But the feedback is really helpful, for me to know how I'm pitching these, and there's a link within the feedback for you to be able to suggest tutorial topics that you might want me to cover. But actually, it also just helps me sort of from my own sort of compilation of the teaching and how it's doing. So please do remember to fill out the feedback. Even if you're watching this, just click the link and you'll be able to fill it out. It takes 2 minutes. So thank you very much. Feel free to watch any of the other videos online, and we'll continue with a sort of investigation series in future sessions.